Morning, everyone. Today we've got Dr. Hervin Heeroo, who will present on inhalational burns, posterior glottic stenosis. You can go ahead, Hervin.
Good morning, everyone. Can you hear?
Yes, we can hear you.
All right. Good morning, everyone. Apologies for the delay. Some technical issues at Red Cross Hospital. My name is Hervin Heeroo. I'm one of the registrars in ENT at UCT. So today I will be presenting on posterior glottic stenosis with a focus on inhalational burns. So for my case, I obtained consent from the patient, and all my content is referenced. So my case this morning is a 9-year-old male patient who sustained 45% total body surface area burns, including inhalational burns secondary to a house fire. He was intubated for 7 days and subsequently developed stridor 1 week post-extubation. On flexible laryngoscopy, he was found to have bilateral vocal cord paralysis with a posterior glottic bend. So this is a video of our DLTB when the patient was taken to theater. I'll just move the video to show the part that's relevant. So for our DLTB, we sprayed the cords with 1% lidocaine. Mobility was assessed preoperatively. The patient was then gently put into suspension. There was a web that was noted on the posterior glottic wall. It's going to appear soon. So release of the web was done using upcutting scissors. And the balloon dilatation was done with a size 8mm non-occlusive balloon for 2 minutes twice, up to a pressure of 10 atmospheres, and no desaturations were noted. So the dilatation was successful, but 3 days later, the patient developed worsening stridor. He was reintubated and ventilated for 1 day. We did a tracheostomy on the patient. So 1 month later, the patient was taken to theater for DLTB with a plan for a possible laser cordotomy. The true cords were immobile and fixed in the midline position. However, we also noted that there was a thick, deep posterior glottic wall scar. I'll just move the video to the parts that are relevant. The posterior glottic wall was released with upcutting scissors and a sickle knife, and a furrow was created to prevent restenosis. The tracheostomy tube was reinserted, and we gave the patient a follow-up date in 1 month for assessment for further intervention. So inhalational injuries occur in about 10% of burn patients and are linked to an increased overall mortality in the range of 25%. Patients with inhalational injury have a reported 20 to 30% risk of developing upper airway obstruction. Glottic stenosis can be anterior, posterior, or complete. The posterior glottis is the most vulnerable area to post-intubation stenosis because of the pressure that is placed on the cartilages and the thin mucosa by the endotracheal tube. The convexity of the tube acts as a fulcrum against the posterior glottis. Tracheal angulation increases the pressure of the tube against the non-resistant respiratory epithelium. 14% of patients intubated for more than 10 days are reported to be susceptible to stenosis. So this is a diagram of the normal posterior glottis viewed from an anterior to posterior direction. Note the vulnerable sites as follows. So you've got the arytenoids, the vocal processes, the interarytenoid muscle that is covered by the interarytenoid mucosa and the posterior cricoid rim. Any mucosal injury that involves the interarytenoid compartment along with 1 or 2 arytenoids and vocal processes may lead to significant airway compromise due to stenotic scar formation. Other risk factors include multiple extubations, reintubations, large-sized tubes, tube motion, and infection. Also, patient-related factors such as diabetes mellitus, congestive heart failure, and a history of stroke or TB have been found to increase the risk of severe laryngeal injury. Posterior glottic stenosis was classified into 4 stages by Bogdasarian and Olson. So type 1 involves adhesions between the vocal processes. Type 2 involves an interarytenoid scar with preserved anteroposterior arytenoid mobility. Type 3 involves a scar extending to only 1 arytenoid, and type 4 involves bilateral cricoarytenoid ankylosis. I will now present a few surgical techniques that are available for posterior glottic stenosis. These have been described in the literature. So the larynx can be entered through a laryngeal fissure. The scarred mucosa and the interarytenoid muscle are resected. The degree of tissue removal and reconstruction is determined by the type of stenosis. So for a type 1, lysis of the scar tissue may be sufficient. For a type 2, scar tissue and interarytenoid muscle resection may be necessary, covered by a post-cricoid advancement mucosal flap. Alternatively, a skin or mucosal graft can be used. For type 3, an aryepiglottic flap may be used to cover the defect. In type 4, arytenoidectomy may also be needed. In all cases, an intralaryngeal stent is kept in place for a variable amount of time, ranging from 5 days to 8 weeks. There are no absolute guidelines for the timing of stent removal. Influencing factors include the degree of stenosis, the type of stent used, and the surgeon's preferences. If the stent is removed before complete epithelialization occurs, then restenosis is likely to happen. If the stent is kept too long, then new granulations, necrosis, and scarring may develop. Submucosal resection is advised to expand the glottic airway while keeping the mucosa intact and avoiding a graft or flap. Two techniques have been reported, membranous and cartilaginous. In the first technique, the posterior glottis is approached using a laryngeal fissure and a mucosal flap on the more affected side is elevated. Scar tissue and muscle are resected between the mucosa and cartilage. In the second technique, the same approach is used for submucosal arytenoidectomy. Inspection of the posterior glottis with minimal intervention through an open anterior approach may be achieved by a limited exploration without laryngeal fissure. Cricothyroidotomy and anterior window laryngoplasty approaches have been described for lysis of type 1 interarytenoid bends. In selected cases, this may avoid possible complications of laryngeal fissure and the need for tracheostomy. Dilatation is the simplest technique, but generally not recommended because of a high recurrence rate. Midline lysis by cold steel instruments or laser may be sufficient for type 1 stenosis. Bilateral transverse cordotomy anterior to the vocal processes was described for type 4 stenosis. Transverse cutting in a coronal plane at the posterior border of the vocal folds creates triangular widening on each side because of the muscular tension towards the anterior commissure. This allows a wider posterior glottic airway passage. Unilateral cordectomy that is performed by a laser can significantly improve the stenotic airway. This can be done either in a submucosal, subligamental, or transmuscular plane. As long as the free edge remains straight and smooth after healing and the contralateral side is kept intact, voice quality is relatively preserved. Revisions may be required as restenosis often occurs to some degree. Arytenoidectomy may improve the airway while potentially keeping the membranous vocal fold intact. Total arytenoidectomy is not recommended because of significant aspiration and dysphonia. Partial laser arytenoidectomy is more acceptable from vocal process to medial arytenoidectomy while preserving the outer rim of the arytenoid. After endoscopic scar tissue removal, unilateral lateralization with a Lichtenberger needle carrier can secure the airway while avoiding stenting or tracheostomy. The vocal fold is sutured to the strap muscles or skin until healing of the posterior commissure takes place. Sutures are removed once arytenoid motion is detected. In case of an immobile fixed arytenoid, the cricoarytenoid joint is released and lateralized by a suture in the same technique. Endoscopic resection with flap reconstruction is another technique that has been described. Release of the fixed cricoarytenoid joints by resection of the posterior commissure skull with or without removal of interarytenoid muscle, followed by an advancement of a posterior cricoid-based mucosal flap towards the exposed region. The flap is sutured to the arytenoid and cricoid mucosal edge, and no stent is required. The flap can also be advanced from the aryepiglottic and vestibular folds and rotated to the posterior commissure. If the patient does not have a tracheostomy tube, then overnight intensive care unit observation should be considered. In our unit at Red Cross Hospital, we put our patients on a proton pump inhibitor as well as Stylodex nebs. The timing of tracheostomy removal depends on its indication, on the indication for its use. If the patient was tracheostomy dependent before the surgery, then often it should be kept in place for months after surgery. And in our unit at Red Cross Hospital, we admit patients for decannulation and observation. So these were my references. Thank you for your attention.
Thank you, Hervin, for that last presentation.
Thanks,
We
Delia.
now ask the audience, are there any questions?
We've also got Dr. Katundu. He's our PEDS Airway Fellow at Red Cross Hospital.
Yes, sure. We'll be happy to have any input from him.
Yeah, so thank you, Hervin, for this very constructive presentation, highlighting the dangers other than the burn itself, which are involved in this important component of the airway. So for Inako, you can see we had quite some challenges in managing him in the first place, in the second place, depending on the degree of the injury from the burn itself and from the tube. So it's always important to highlight to even other colleagues when taking care of this patient, they should not forget to care for the airway. As you can see, the management is quite tricky and it involves several stages if the initial stages doesn't work properly. Yeah.
So thanks, Hervin. That was a very nice presentation. I have very minimal experience with these patients, but I don't know what the literature kind of shows in terms of results for these procedures, but I would imagine for kind of a lot of the more advanced, especially the open procedures, the potential for complications, potentially creating a worse or more challenging airway situation is also there. Does the literature kind of advocate for a more graduated approach? Or more tailored approach according to the anatomical or the classification of the posterior vicious stenosis?
Yes, thank you, Matt. So from the systematic reviews which I use from for my presentation, the normal approach for a type 1 interarytenoid bend would be resection. If this does not work, the next approaches would be more invasive ones, such as laryngeal fissure. So they would start with dividing the posterior stenosis, as we did. However, balloon dilatation is not recommended because of the risk of restenosis. There are also some papers which describe good success rates with stent insertions, which we have not explored yet. In my presentation, I mentioned that we wanted to do a laser cordotomy for this patient. However, this was based on a flexible laryngoscopy that we did a few days or before the intervention. At this point, we thought we'd be able to free the right arytenoid for a laser cordotomy. However, when we went into theater, the bend had worsened, so it had progressed from a type 2 to a type 4. So there was no room for a laser cordotomy. So we decided to release the posterior bend with a deep furrow. We reinserted the trachea, and so the next stage in our approach would potentially be an open approach with stent insertion.
Thank you. So we've got a question from the audience. Does mitomycin C have a role in preventing granulation development following resection of bands? Any experience with its use?
Yeah, so literatures and practice have a few information about the role of mitomycin C, but there are good evidences from other parts of the world concerning the use of topical steroids, and this is have been already explored also from the level of the glottis. So mitomycin C, the literatures are really scarce and the practice is really limited.
Thank you. Thank you.
Can I ask one more question? To you as well, Rob. Just for these patients, what is a realistic expectation in terms of an endpoint? Are you just trying to achieve a decannulation for the patient, or is it realistic that patients can get back to their airway in terms of baseline without any effort tolerance? One expect them to continue to have ongoing dysphonia and a degree of reduced effort tolerance, because I think it's quite important, obviously, how you counsel the patients.
All right. I don't have much experience in terms of managing those patients, but from the systematic reviews which I've used for my presentation, there are quite good outcomes which have been reported in the literature. So the ultimate aim is to achieve an open airway where the patient can resume normal daily functional activities. Maybe Dr. Dennis will give us some more insight.
So the aim is always almost targeted towards resuming the patient to the natural airway, but that is not a one-day miracle. It will take a process from the reconstruction point up to achieving the cannulation. So from what I've had already from this part of the training and what I've seen from other parts of the world, it will take a minimum of 36 months to achieve the good airway, with initiating the conservative management up to the aggressive management if it reaches that point. But the ultimate is the decannulation.
Thank you so much. All right, so we'll end the meeting and we'll meet on Friday. Thank you.